Hi, everybody. This is Kate Mills, physical therapist, neurological vestibular specialist. And I just wanted to share a pet peeve, a maybe, I guess, unpopular opinion in physical therapy or rehab in general, but should not be among neurologic physical therapists, but it is so common and on my mind very recently because I am spent several months now with a patient who is doing very well following a stroke, but his stroke was maybe 7 years ago. So he has gone through very intensive physical therapy in the hospital and then a long period in acute rehab and then outpatient for many years. And so he's had the experience of having many different physical therapists. And he came to me on a cane thinking that he had really progressed from where he couldn't barely walk at all and was dragging his involved side, in his case, his left side around, just dragging it around. And then he was taught how to walk and started with a walker. He has use of the left side of his body. He has almost full active motion. His main deficit is an attention issue. He's not complete neglect any longer, but a definite inattention. So as long as he's looking at that left side, he can make it do anything he wants, upper and lower extremity, arm and leg. But he comes to me on a cane, and I'm gonna do my best to see. So the idea being that, keeping in mind, okay, so he's a left-sided involvement. He has dropped foot. He's not wearing an AFO. I guess that's never been enforced either. So in order to compensate, he's got his leg out to the side and he's on this cane and he's just pulling that leg and that arm around, and has been told by some therapists, as well as it's obvious that he believes that because he's only on a single point cane, and by the way, I don't even own a cane in my clinic. I don't have a cane. So this is a walking pole, and I'll get to that in a little bit. But the patient is always going to think, patients and family members are pretty much, they're trained to think because of orthopedic therapists and the most prevalent exposure that people, the most common exposure that people have in their normal lives is orthopedic rehab. Somebody had a total hip in their family, a total knee replacement, sprained an ankle, something. And the normal progression there is they might have to start on a walker because they need both sides support, heavily relying on their arms to unweight that side that's painful or recovering from surgery. And then they progress from a walker to maybe crutches or to a cane, and that is a definite sign of progression. Neuro, specifically patients with a unilateral involvement, so largely strokes here. It is not progress to switch a patient from walking where they are in midline, closer to midline, with both extremities supported. I'm gonna toss this up here for a second and see if I can, just so it is clear here what I'm getting at. I know for therapists it will be, but anybody else watching. So here you have two ends. Even if this side is flaccid, you can't move it at all. It's not doing anything at all. Having it on something, I don't have a platform walker right here, right now. So this is what I'm using to demonstrate. Having a walker that supports the arm and has, really, I like 4 wheels better, because it promotes a nice natural gait pattern. They are much more safe and more likely to shift to this involved side, which is the only way that they are going to start to get return of active muscle contribution, active movement in the leg and the arm is through weight bearing. So this is where they should be always, two sides supported, unless they can hold that device, that single-sided device in one hand, and that hand is their evolved hand, then please, 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 therapists, stop putting your stroke patients on a cane on their uninvolved side to drag around their involved side. It's taken me this long to just sort of get him rewired to not be so fearful, like he's falling off the edge of the earth when he has to weight shift into that left side, because he's been dragging it around for 7 years and nobody said there was a problem with that because he could walk. So real quick, the other thing I would say is I totally get that there is a compromise between being, ideologically perfect in a neurologic world. Nobody would ever be on a one-sided device that doesn't include their involved side at all. There is a compromise in therapists that are working in a inpatient setting, inpatient rehab, that they need the patient to get home safely and not be in a wheelchair. I understand that. So something like a walking stick, this is a walking pole, so I had the one shrunk all the way down to where a cane would be, but at least get them up higher so they're not bending down even farther, relying on that involved side. To put it bluntly, they don't need us to teach them how to do that. Their brain, the side of their brain that wasn't affected by the stroke, is gonna figure that out by themselves. They are gonna drag that side around till the end of time. They will drag it till it bleeds. Like, they do not need to pay a physical therapist to teach them how to do that. So doing the hard work means spending the majority of the time forcing that weight shift, giving them your manual cues, whatever, giving them something to weight bear through that side. And the best of all circumstances is only that side. Because when their brain has to focus on, if I don't weight shift here, there's no way I can take a step with that good side, in this case, my right side. If I'm not holding this pole or keeping my arm on a platform, if they don't have grip, if they're flaccid, if they don't have any use of it, even more so, you should have that shoulder supported. It should not be hanging down where it can sublux. So should always have support under the involved side. And when they get that sort of anxiety that comes with, I can't take that step with my right leg because I don't have anything over here to support me. That is the hard part. But when you start to get them over, have them leaning into a wall, something where they feel safe, and just take those forward and backward steps on, do this, just have them shifting on, you're supporting the involved leg, they have something supporting the involved arm, whether it be a platform, walker, or a table, or if they can grasp this. And then they're just going practice forward and backward with the uninvolved side, with the good side. So just make them weight shift onto this side. I think we concentrate so much on them taking steps with it. Weight bearing, weight shifting is what gets things to come back. And I don't think I've ever seen a patient that comes to me years after a stroke that has not been encouraged by the majority of their therapists, all of their therapists, to, once you can get off a walker, get on that hemi-walker. Oh, even better, a 4-pronged hemi-walker. Now you can really drag that side around. You're killing me. So please, therapists, patients that are listening to this, I encourage you, just do the hard work up front. Train them for short periods of time with a walking stick, so they can get from A to B at home and be safe. But spend the majority of time making them shift to that side. I'm going to include a link in the comments. Now they're everywhere, honestly, but these like bilateral platform walkers, I used to always have to use a rep to get them from a specific DME company, but now they have them, Amazon. So I'm going to include a link. So that bilateral platform, it has a seat and 4 wheels. I love that. It keeps them upright. You're not encouraging this asymmetry that they're so prone to anyway. So that is my rant for now. And I will try to include any other links for maybe potentially useful devices. But thank you. Thank you for your time and listening to me rant. Kate Mills, neuro and vestibular physical therapist, owner of Be Balanced, Centerville, Maryland. Bye.